Let's talk about pain, chapter 8. And it's important for us to learn this chapter and understand this chapter because there's so many types of pain, so many experiences of pain, and so much connection between the mind and body that we've learned to understand. So the first thing we want to start out with is the definition of pain. The International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. McCaffrey, a nurse and leader in pain management field, has a more useful definition for nurses, and that's pain is what the patient says it is, pure and simple, because we cannot imagine what the patient is experiencing. Excuse me. So we can't judge. We can't say, yeah, they have pain because they're not making a face or they're not wincing. We just have to say it is what they say it is. So the perception of pain involves afferent and efferent pathways. So afferent pathways, now this is on figure 8.1, which is on page 133. So I'd like you to look at that. So the afferent and efferent pathways. So afferent pathways are ascending. So the afferent ascending, activated by pain receptors called nociceptors. And those nociceptors are unevenly distributed in muscles, tendons, and subacute tissue. It's important to remember that. When pain receptors are stimulated, impulses travel up the spinal cord to the brain. That impulse is interpreted by the brain in the cortex, and it identifies the location and the quality of the pain, and then you may experience stress and fear. Once that pain is transmitted to the brain and spinal cord, the descending pathway is activated and endorphins and encephalokines are released. And those are our natural hormones, our natural pain relievers. And they can block that transmission of pain. So the gate theory, I think, is an amazing, amazing theory. It's on page 132. And there's a really good picture on page 133 of the different pathways, the afferent, efferent pathways, the ones going to the brain and the pathways coming to the brain, the small diameter and the large diameter pathways. So painful impulses are transmitted to the spinal cord through small diameter nerve waves in the afferent pathway. Factors that cause the gate to open include tissue damage, a monotonous environment, and fear of pain. So see, not just the pain itself, but the environment and the fear can cause pain. So the stimulation of large diameter fibers can close the gate and interfere with impulse transmission between the brain and spinal cord. These large diameter nerve fibers are stimulated by skin stimulation through massage, position change, that's supposed to be heat, heat or cold applications, also distraction, guided imagery, and information. So let me give you an example. There's two examples I have. One is childbirth, and that's how we teach the breathing. So during contractions, you're supposed to be breathing. Well, the idea behind that, I know you're going to say it doesn't work, but the idea behind it is the gate theory. And that is, if there's pain going into the brain from a contraction, if you're breathing, then theoretically that pain can't get through because only one message can go to the brain. And right now you're breathing. So you're blocking the pain. Another theory that goes along with this is, let's say, have you taken your child, or maybe you've gone to get a shot, an injection at the doctor's office. Well, let's say it's a child. And so just before the injection is given, the nurse pinches the child's toe or maybe pinches their leg, and then the child focuses on that pinch but doesn't even notice the needle going in the arm, because it's different pathways that are being stimulated and blocked. So it's really pretty amazing, isn't it? I really like the massage part, because if I'm getting massaged, or not just getting massaged, but getting a massage or massaging an area that's uncomfortable, it makes it feel better, doesn't it? You know, how many times when you get injured do you rub that area? Well, it's because you're trying to stimulate your nerve fibers so that you don't feel the pain so much. Also, how many times have we put heat and cold applications? Sorry, that says here, but it's supposed to be heat. Heat or cold applications, those help take our pain away or relieve the pain. Also distraction. So you can be in pain 1 minute, and what if you see something that you get really excited about, and then you're distracted from the pain, which is also kind of the theory with the child. They're distracted, maybe with lollipop. They're given a lollipop and they're so into that lollipop, and they don't pay attention to the shot or what's being done to them. So distraction is a great thing to use even with your patients. TV can distract a patient from their pain. Just talking to them can distract from their pain. A magazine sometimes can distract. Music, I'll get into this more. But there's so many ways we can distract our patients from pain. This also mentions guided imagery and also information. Remember, I've also always said knowledge is power. Well, if you know why the pain is happening, you understand what's happening or what's going to happen, it makes it a little less stressful, a little less scary, and therefore that lowers the pain. So factors that influence the response to pain, everybody experiences pain differently. Although people may have the same injury or insult, they may respond differently because of many physical and psychological factors that can affect the response to pain. We're even going to talk about medications later, how those can actually make the effect of the response of the pain different. So it's important for us as health professionals to be non-judgmental and to avoid comparing one individual's pain to another, because it's not the same. It can be the same kind of pain, but they're going to respond differently. So we can't judge them. We don't know what their life has, what they've experienced in their life that has got them to this place. And so we're just looking at them in one window, and do not be judgmental here. So there's some physical factors that can affect, and it's really important that we understand pain threshold. So pain threshold is the point in which a stimulus causes the sensation of pain. Anger, fatigue, anxiety, insomnia, depression, and uncontrolled pain all lower the pain threshold. And with a lower threshold, the person experiences pain more readily with less stimuli. So I want to point you to, if you'll turn to page 152, there's a little question here, number 3. And it says, Mr. A and Mr. B both had back surgery yesterday. Both had the same pain, the same surgery. Mr. A has used his PCA regularly, which is patient-controlled analgesia. He says that he's pretty comfortable, and he sleeps most of the time. Mr. B has used the maximal analgesic permitted by the PCA, and they are controlled. They can only get so much per hour. But he's used his PCA and has required additional analgesia twice while continuing to complain of some discomfort. Of the following, which is the most likely explanation for the difference in the pain experience of these two people? So this is pain threshold. So the answer is number 3. Mr. B has a lower pain threshold than Mr. A. So he's requiring more medicine. It's kind of the opposite of what you think. His threshold is lower because he's feeling pain more, if that makes sense. So pain tolerance is the intensity of pain a person will endure. How much can they tolerate? Some can tolerate a lot, some not any at all. Redheads are very commonly, in fact, I've had doctors say, oh no, a redhead, because I don't tolerate pain very well. And so doctors know that. And maybe some of you redheads out there know this to be true as well. Another thing is age. So age can influence responses to pain. At times, older patients do not report their pain or they report that their pain is much less severe than it really is. Some don't report pain because they are stoic, or they have been told incorrectly that pain is a normal part of aging. It is not a normal part of aging. Physical activity and nervous system integrity. Physical activity may aggravate or precipitate pain. So if you've injured yourself, physical activity can make the pain worse, can't it? Yes. Surgery and anesthesia. Surgery on the upper thoracic abdomen are more painful. This is interesting, I think. Nerve blocks into joints. Now this is important to know about nerve blocks. It's in your book on the bottom of page 133. So nerve blocks or injections into joints can reduce pain, and sometimes they give femoral blocks before hip surgery, so just that area is blocked. I know some hand surgeries are done that way too. The patient's awake and there's just a block on the hand, maybe carpal tunnel surgery. So just that area is blocked. It's called a femoral block. In the hip, it can be a hand block if it's a hand, but the drugs are injected to block the transmission of the brain of the pain signals. So those femoral anesthetic nerve blocks may be performed before hip surgery. So that's important to know. Did your patient have that? That's important to know. So be sure you read your chart. What did your patient have during surgery? How much pain medicine did they require? How was their attitude before surgery? This can all affect how they get better. So speaking of that, let's talk about some cultural factors on page 134. So culture and ethnicity. So some studies have been done to determine the effect of culture, ethnicity, and gender on people's reaction to pain. So don't make any judgments on anyone. Some persons may deny pain, remain calm and unemotional, or withdraw, while others cry and moan and groan and involve their whole family and get everybody all stressed out and reacting to this person's pain. Sometimes that's a gain, isn't it? They gain a little attention that way. Then there's some religious beliefs. They may also have an impact on pain. Patients may pray and believe their divine intervention will help them to endure the pain. Others may view pain as punishment. So they endure the pain because it is a punishment for something they've done in the past. Past experiences and anxiety. So a patient may have developed positive coping strategies to to deal with previous painful experiences. If, however, previous coping strategies were unsuccessful, the patient may be very anxious and overwhelmed by another painful experience. They're thinking, oh, it didn't work before, it's not going to work now. But it's our job as nurses to encourage our patients to try it again or to try something different. So we're going to have a lot of tricks up our sleeves for pain management, and you should, because as I said before, nobody's the same. What works for one person doesn't work for another, but we have a lot of options. So situational, so if the pain is associated with a serious illness or condition, such as cancer, the pain may have a greater impact on their mood and their activity. So they might not want to do anything. They might even get depressed. So it's situational depression because of their condition. And then they have to endure. They're thinking of all the things they're going to have to endure and go through, and everyone it's going to affect. I mean, it's just a fact that just goes on and on and on. We can't let that happen because it can just blow out of proportion. So let's talk about the autonomic nervous system. So that's the fight or flight response. It's our automatic nervous system, and certain physiological responses are initiated. So the nervous system response is measured by increased heart rate. And this is important for you to know because we're going to be talking about this, and this is going to come up forevermore. So we might as well learn it now, right? So the nervous system, increased heart rate, this is the autonomic. And I always talk about the caveman going out hunting for food. He's looking for food in the dark. There's a lion in the woods maybe, but he's going to eat. Who's going to eat who, right? You're nervous, increased heart rate. You're looking, your pupils are dilated, your respiratory rate's up, you're breathing and you're looking, your blood pressure's up, and you're either going to get that lion or the lion's going to get you. So that's your autonomic nervous system. Also, there's, I do believe, box 8.1, not table. Remember, we have boxes and tables. So if you look at box 8.1, increased blood pressure, increased pulse rate, increased respiratory rate, dilated pupils, you might perspire, might get a little pale or have some pallor. So conversely, the parasympathetic nervous system responses are constipation and urinary retention. All right, so autonomic nervous system. So this can relate to pain because if this autonomic nervous system is stimulated during pain, you're going to have an increased heart rate, an increased respiratory rate, an increased blood pressure. Have you ever heard of the white coat syndrome? Well, some people, when they see a white coat, like a doctor's white coat or a nurse's white coat, they automatically get this autonomic nervous system intervention. And the nervous system response, the increased heart rate, increased blood pressure. And here you are getting your blood pressure checked, and it's up high. But it's not, doesn't normally run high, but because you've got the white coat syndrome, you're just nervous, really. So acute and chronic pain elicit different kinds of responses. And on page 135, it has table 8.1, which is differences in acute pain and chronic pain. And we're going to talk about that. So acute pain first. So acute pain on page 134, it follows the normal pathway for pain, from nociceptor activation to the brain, and it may even be called nociceptive pain. Causes known and treatable, like post-op pain, you know you're going to have it. Kidney stones, fractures, childbirth. It serves as a warning of tissue damage and subsides when healing takes place. Behavior and psychological signs. So when the patient guards or rubs a body part, wrinkles their brow or bites their lip, and has a change in their heart rate, blood pressure, and respiratory rate, those are physiological signs and behavioral signs, the biting of the lip, the wrinkling of the brow. So if you'll notice too, all right, we'll go on and then we'll go back and look at the acute and chronic pain. Chronic pain, so it's persistent. It recurs for more than 6 months and even a lifetime. Chronic pain may be nociceptive like osteoarthritis or neuropathic pain because it follows an abnormal pathway for processing pain. Now, neuropathic pain is caused by nerve damage resulting from anatomic, physiological condition and underlying diseases. So what comes to mind here? Diabetes, Because diabetes, we know, causes nerve damage in the legs, and we get neuropathy in the legs, and that's a neuropathic pain due to nerve damage. Some patients with back pain get neuropathic pain in their legs as well from nerve damage. The sciatic nerve, you can get pain like that. Includes unusual sensations. And this is important to know, these kinds of pain, these neuropathic pains. And how do they manifest? Well, these sensations, this neuropathic pain, and it's in your book on page 135, neuropathic pain is caused by nerve damage resulting from a wide variety of anatomic and physiologic conditions and underlying diseases. You know that when I repeat things a couple times, it's probably important, right? So, it causes unusual sensations such as burning, shooting pain, abnormal sensations that occur when there is no painful stimulus present. So this chronic pain can be associated with cancer, arthritis, and traumas. Now, phantom limb pain is another kind of pain that occurs with an amputation. So even though the amputated right leg, let's say that right leg is amputated, phantom limb pain is when they still feel pain in that right leg, even though it's not there. Now, believe you me, they think it's real. So we have to treat it like it's real, right? Even though we don't see a leg or to even have pain in, but it's real to them. So therefore it is real. Well, we shouldn't be saying things like, you don't even have a leg there. That doesn't cause you any pain. It's real to them, and it is what they say it is. So let's compare acute and chronic pain. So chronic pain really serves no useful purpose. It's just nagging, always there. We have a disease, we have something wrong with us, and it's always there. An acute pain warns us of tissue damage or trauma, something we need to take care of or needs to have taken care of. Now, if you look on page 135, it does compare acute pain and chronic pain. And you can say acute is short-term, longer than 3-6 months. Purpose of acute pain, there's tissue damage. Chronic pain, it's just gnawing pain. Verbal, they report pain in acute pain. Chronic pain, they might not say anything. So you can read through the two differences there. It's important to know the difference between chronic and acute pain because chronic pain can lead to depression, marital difficulties, loss of self-esteem, immobility, and isolation. Because when you have chronic pain, you just really don't want to do anything. My sister had chronic pain, and I used to say, Well, you know, she goes, I can't exercise, I can't do anything, I have this pain. And it's like, well, why don't you take a little walk outside and enjoy the outside? So I was offering her distraction, right? Go outside, the leaves are changing, it's fall, you can smell the different smells. No, she didn't want to do that because she might fall. This might happen, this might happen. So she was depressed, you know. She had chronic pain and it led her to not want to do anything. So she became isolated. She didn't want to leave the house. Also, immobility, the fear of even having that pain sometimes come immobile. You just want to lay in bed and be comfortable in your bed. That loss of self-esteem because you don't go anywhere, you don't get fixed up, you don't look that good, and you just feel like you're a drag to everybody. Can lead to marital difficulties as well because you're chronically complaining. God bless the loved one who has somebody with chronic pain and they have to listen to them complain all the time. But they're so patient, and there are people like that. So in chronic pain, the sympathetic nervous system adapts. The nurse may underestimate the pain because the body has adapted to the pain. So I'm telling you this because there's some cardiac meds that block that increase in heart rate, that autonomic response of increased heart rate and increased blood pressure that you normally would have with pain. Well, some cardiac meds, especially beta blockers that lower the heart rate, their heart rate's not going to go up because they have medicine on board blocking it. So this is another thing that pain is what the patient says. Because what if they're on meds that's blocking that autonomic response to pain? So remember that. Okay. So I'm giving you two examples of types of pain and how to do nursing care in pain, how to do our assessments, because it's really important. So the one on the right side here is the nursing care of the patient in pain. So we do our assessment. So we have to assess the patient. We have to accept the patient's report of pain. Determine the status of the pain. Is there something there causing the pain that we can see? We need to describe the pain, and when we're documenting, be sure that we do that. So where is the pain? Describe the pain: shooting, stabbing, sharp, dull. Examine the site of the pain, because what if there's a pin underneath the sheets, right, that's causing the pain? So we want to examine the site. Or what if they've had an incision and it's opened up, and that's why the pain is there? So examine the site of pain. Identify their coping mechanisms and document. So another way, I have the PQRST mnemonic that gets a complete pain history. So P is what provoked the pain. What makes the pain come on? What causes the pain? What makes it worse or better? Q is the quality of the symptoms. What does it feel like? Is it sharp, dull, tingling, stabbing? What region of the body hurts? What's the location? Is the pain focal or does it radiate to a different location? The severity, using a scale of 1 to 10 or the FACES pain scale, and we will be talking about this, but I just put this in here because I don't know, maybe you learn this way, you need a mnemonic to remember things, or maybe you can just learn the information. So severity, we use the pain scale. Time frame, so when did it start? How long did it start? And then when you give them pain medicine, how long does it take to go away? All right, so one thing I want you to know that's important is that in 2001, think about that, nine years ago, the Joint Commission standards policy to rate pain. So we didn't really have a specific way to rate pain like we do now. And that includes patient involvement in pain management, develop strategies, pharmacologic and non-pharmacologic. So these standards had to be put into practice. They had to be told to us. Rate the pain. You have to. The Joint Commission says so. So rate the pain. Include the patient in their pain management. How do they want to do this? We can't make them do something they don't want to do. Develop strategies for the pain management that involves the patient. Pharmacologic and non-pharmacologic treatment. So that would be medication and maybe massage, or medication and music. And then establish goals. So by 1 week, let's say, the patient will be pain-free. Or in 3 days, the patient will have walked the whole length of the hallway. So we need to establish goals. So that was something in 2001 that the Joint Commission came up with. All right, so let's move on. Let's try a question. So factors that increase endorphin levels, remember endorphins, what they are? Include all the following except morphine, sexual activity, exercise, and laughter. So endorphin is natural. It's your own way of making you feel better. So the answer is A, because that's a medication. So research suggests that prolonged stress and pain, as well as the prolonged use of morphine and alcohol, decrease endorphin levels. So people who have been on long-term pain management, they don't have any endorphins to make them feel good. They don't have any feel-good hormones. Factors that increase endorphin levels include stress and pain management, laughter. A good laugh can always make you feel better. Exercise makes you feel better. Acupuncture is another treatment. And a TENS unit, we're going to talk about that also. It's called the transcutaneous electrical nerve stimulator, or TENS unit. Massive trauma and sexual activity. Try another question. So which of the following is a true statement about pain? So I'll give you a minute to read through there. So if you guess C, you're right. Sorry. So C, anxiety, fatigue, or loss of sleep can lower the pain threshold or cause the patient to experience pain more easily. That is a great definition of pain threshold. Causes the patient to experience pain more easily. And that can be anxiety, fatigue, or lack of sleep, which we know in the hospital you don't get much sleep. Sometimes at home you can't get much sleep. So the answer is C. So now let's talk about assessment. Very important. Page 136 to 140, I'm going to be going through several things. So assessment always begins on admission, and it's continual. It goes throughout the admission. You're always reevaluating, assessing, reevaluating, changing. Things change from day to day. Pain is called the fifth vital sign. There's 6 steps, and it talks about that on page 137. It's called 6 Steps in Pain Management. So you accept the patient's report. It is what the patient says it is. You determine the status of the pain. And how do you do that? Determine the status of the pain. Well, where is it on a scale of 1 to 10? Describe the pain, the location. Now, here I want to bring up something called referred pain. So location of pain doesn't always correspond to the actual place of pain. And I'm thinking here of heart pain. So you know the heart, where the heart's located, but sometimes you have pain down the arm, up the jaw, around the back. That's referred pain. It's not in the heart, it's referred elsewhere. There's another kind of pain, appendicitis. So appendicitis doesn't always hurt in the right lower quadrant. Sometimes it hurts at McBurney's point, which is up by the belly button. So the doctor pushes up there and they get referred pain into the appendix. Then there's intensity of pain. So this is where the Wong-Baker faces comes into effect, and that's on page 138. I'm sure you're familiar with these faces. 0 is no pain at all. That's a happy face. And it goes all the way through to 10, where it hurts so bad you're crying. So that's the Wong-Baker. It's 2 doctors. They created this. It started out for children because they don't know 1 through 10, but they do know how they feel with a face. They can identify with a face. We may say 1 through 10. What is it? 1 being the least, 10 being the worst pain you've ever had. We'll give it a number, but there's also the Wong-Baker faces, and those are on page 138. Then aggravating factors. What makes the pain worse? And it's like, does it hurt when I do this? Does it hurt when I do this? So, you know, you can move the arm around. Let's say it's in the arm. So what makes it worse? What brought it on? Examine the site of the pain. That's really important because you might not see anything, but you might see a big old bruise, or you might see a wound opening up, or you might see a broken bone. You know, because remember, not everybody has the same intensity of pain. Some people can walk around on a broken foot, and then they finally get an x-ray and find out it's broken. They've been walking around on it for a week. Identify their coping methods. What helps them feel better? How can they cope? What is their coping mechanism? So what helps them relieve the pain? Do they get up and move around? Can they turn on their side? Do they go to sleep? What helps them relieve pain? Document your assessment findings and evaluate interventions. And then another type O note box 8.4. I was pointing you to the cognitively impaired patient. So that's on page 140. I want you to know this because it's important, because you're going to have cognitively impaired patients. How do you know when they're in pain? They can't tell you. So under box 8.4, common pain behaviors in cognitively impaired older adults, notice their mental status change. Crying, increased confusion, irritability, distress. They can't tell you what's bothering them, but they know something's wrong, so they're acting up. Important to know that. All right, starting on page 140 now, I'm going to be talking about some non-pharmacologic and pharmacologic ways to relieve pain, or interventions. So non-pharmacologic interventions would be comfort. Turn the patient, position the patient for comfort. Use pillows, make them comfortable. Some cold helps patients with their pain, but it is contraindicated for patients with peripheral vascular disease. Now, why would that be? They can't feel it, so they don't know when they're getting too much cold. So you have to limit it to 15 minutes. So cold can help pain, 15 minutes only. Heat can help, especially for muscle, joint pain, sometimes cramping. 30 minutes for that one, because that will prevent tissue injury. So cold and heat is great, but remember there's limits. With cold, it's 15 minutes. With heat, it's 30 minutes to prevent tissue injury. All right, guided imagery, some patients use that. And that's like, I picture it, so they look at a far away, maybe a picture, and they think about Hawaii. Think about the ocean coming in and out, the wind blowing, the smell of the air, the dolphins jumping in the ocean, the waves. So that's guided imagery. They're guided to an image. Oops, I hope you guys didn't fall asleep. All right, relaxation techniques. So maybe music, maybe deep breathing, maybe meditation. Meditation tapes are great for that. Control the environment, and that could be listening to music or watching TV. You're controlling the environment to make you feel better. I feel better when I'm listening to music. Headphones, just, it blocks out all the other noises, especially in a noisy hospital. Listening to music is a great way. I had a patient who was almost comatose. He was paralyzed from the neck down. Let's put it that way. He couldn't move his arms or legs. But boy, when we put a headset on him and he listened to music, or if we rolled him into the activity area where they were having karaoke day and he heard the music, his eyes just lit up. So it can really help patients. Music can also calm patients down. I had a patient once who was very agitated, turned on the radio, and the music calmed her down. So it can really be very helpful, a helpful tool. Watching TV, I don't like to use that one as a diversion necessarily, but it works for some people. Some of the elderly like black and white TV shows, I've noticed. And also visitors can help distract them. In the environment that they have visitors come and they can talk to the visitors, and they're distracted from their discomfort. So here's that TENS unit. And I want you to remember this is stimulation of the skin and underlying tissues to relieve pain. These techniques are not curative. Rather, they can decrease the intensity of pain or change the sensation so it's more acceptable. The exact mechanism for pain relief is unknown, but the belief is that superficial stimulation can block the transmission of pain impulses. Gate control. So that's the idea of the TENS unit. And that is on page 141. The heat and cold is there also. Talks about cold and hot and how intermittently, remember cold is only 15 minutes, heat or heating pads, 30 minutes. Massage. Massage is a great thing. Good back rub will make a patient feel great. When my mom was in the hospital, a good back rub, nurses don't give back rubs like they used to. When I went to nursing school as an LVN, I had to learn how to give a good massage. That was part of my training because they knew even then how important massage was. Plus, it helps the skin, right? It stimulates the skin so that they don't get skin breakdown. So it works twofold. Anxiety reduction. So I wanted to refer you to the health promotion box, and that's on page 142. Sample relaxation exercises, the slow rhythmic breathing, concentrating on the breath, mindfulness of the moment and breathing. Concentrate on the breathing. So that's another really good way to kind of it takes you away, actually. Can. So some pharmacologic interventions. So one recommendation that I'll say is, and it's in the book, I'm not just making it up. When administering analgesics, you need to use a preventative approach to pain management. This is on page 143, second column. When pain is predictable, like post-op or cancer, they should get around-the-clock ATC medications. Don't wait for them to get into pain before you relieve their pain. And I'm not saying you should give everybody medicine whether they want it or not. What I'm saying is that when it's anticipated or predictable, don't let it get out of control. It takes so long to get pain back under control. So around the clock rather than as needed or PRN. It maintains a therapeutic blood level. Therefore, they get a constant control of their pain. With a PRN schedule, the patient may have frequent periods of unrelieved pain and may have more significant and frequent side effects such as sedation. Sorry, I missed my place there. All right. Let's go to non-opioid analgesics. So those would be like aspirin, acetaminophen, NSAIDs. So those are good for aches and pains, arthritic pain, backache, headache, dysmenorrhea, some post-op pain, cancer pain, and bone pain. It's a good fever reducer. We know that Tylenol and aspirin can do that. All right, we'll turn to page 145 and talk about opioid medication. Opioid analgesics are generally used for moderate to severe acute pain, chronic cancer pain, and some other types of pain. Some examples are codeine, methadone, Dilaudid, Demerol, and fentanyl. So I'm going to go to the next slide because I want to talk about this more. So opioids. Opioid agonist drugs. Now I know you're going to get this in pharm. So the idea of these drugs, they fit into the receptor site of the pain and produce the drug effect, which is a pain reducer. Examples: methadone, Dilaudid, Demerol, fentanyl. Now there's opioid agonists, antagonists that bind to opioid receptor sites to produce analgesia and bind to receptor sites to block unwanted side effects like nausea or sedation. So those aren't good because you may not want too much sedation because it can suppress the respiratory rate. An example of that would be Nubane. And I want you to always remember that older patients are more sensitive to analgesia because of delayed excretion from their kidneys and liver, and they have slower metabolism, and their side effects may be more pronounced. And when changing from parenteral to oral, which you have to do to discharge a patient, they can't go home on IV drugs, the prescriber may adjust the dose and it may not look the same. Your patient may say, hey, I was getting 50 milligrams of Demerol and now I'm only getting 5 milligrams of Norco. That's quite a drop. Well, yep, they're different drugs and they're distributed in different ways. So the dosage is adjusted per the drug. It's important that they understand that. Also take aspirin, 81 milligrams of aspirin, what does that do? It's a blood thinner. But at a higher dose, it relieves pain. So everything is dosage adjusted. Important to know that. Okay, pharmacologic interventions, some misconceptions. So patients, families, and nurses and physicians have misconceptions about addiction. Therefore, the term must be defined and differentiated from the term tolerance and physical dependence. Tolerance and physical dependence are normal responses to opioid administration for pain. They do not lead to a craving for the drug for its mind-altering effects. That's addiction. And sometimes the fear of addiction is greatly exaggerated when actually it's rare. In fact, less than 1% of people get addicted. So they shouldn't fear that, but sometimes they do. So I put this slide together just because I wanted you to realize on 146 to 147, there's different types of administration of drugs. There's an IM injection. It's not real practical for repeated injections. It's okay every once in a while or for breakthrough pain. It takes a bit to be absorbed. IV instant absorption. So got to be careful with that one. And remember, we always want to use our aseptic technique. Oral routes always preferred over anything. So then there's the PC, or the patient-controlled analgesia. Now, that is great post-op because the patient, you're not running to the room every 15, 30 minutes because of pain. The patient can push the button. This is good for, I understand they use it in birthing situations too, where they have a spinal analgesia. They can control it themselves. So they can push the button as many times as they want, but they can only get so much every hour. It's controlled. It is patient controlled because they can push the button, but it's also controlled by you, how much, or by the physician, how much they can get. Then there's liquid. That's good for people. Some people can take it intranasally as well, sublingually as well. Patches are good, used to treat cancer and chronic pain. They usually are about 72 hours that you put them on. One thing you need to remember about a patch is to date it so they know in those 72 hours. Now, it's marked in the MAR every 72 hours, but you need to know, too, when it was put on to be sure it was the right time. Some nurses, I'm sorry to say, they may not give the patients the patch. So the date may be wrong, so be sure you date it. You don't want to be accused either. And then when you remove that patch, wipe off what's left because you don't want the patient to get overdosed either. And you might want to put it in another area of the body, but a place where people can see it, not on the back where no one can see it, on the front, a non-hairy area so it can stick really well. So some side effects regardless of the route of administration. This is really important to know. Opioids cause constipation. Doesn't matter the route, they can still get constipated. So it's important to give patients on opioids, painkillers, stool softeners, and be sure they drink fluids. And also on page 147, I talk about CNS depression or the sedation scale. So it's important that we watch for CNS depression. What is that? Well, that's where your central nervous system's depressed. So your breathing might be decreased. And this is especially observed with IM medications because you don't know how quickly that's absorbed. You don't know how much they're getting at one time. You know you gave a shot, but you don't know how it's distributed in the body. So you have to really watch for that CNS depression in an IM injected patient. So take a note of that box 8.6 sedation scale. So pharmacological interventions, what are some other things we can do? So drugs not usually classified as analgesics, but they may relieve pain in certain situations. So for instance, muscle spasm. I have pain in my neck, but it doesn't require an analgesic, it requires a muscle relaxer. So you might need to give a different drug. A patient who has undergone back surgery, oh here it is, complains more about muscle spasms than incisional pain, so you give them a muscle relaxer. Specific pain syndromes, especially neuropathic, may be controlled with drugs other than the commonly known analgesics. So what about problem solving with pain medication? So patients ask questions about the analgesic drug. What do they take? What does your patient take? Be sure you do the 5 rights. I believe it's 6 rights now that you do documentation, which is very, very important. Right dose, right patient, right time, right route, right analgesic, and right documentation. And determine why the patient's not getting adequate pain relief if they're not getting relief. Why is it? Is there something else bothering them? Is there some other medication you need to get ordered from the doctor? These are problem-solving questions that you need to ask yourself. And you can look on table 8.5. Why did I say 8.8? Oh yeah, that's a box, so that's problem-solving with pain medication. But I also want to turn you to table 8.5, which is the one before that, and that's just some adjuvant drugs and pain medications that can be used besides the ones that are ordered or that you might ask the doctor in addition to. What if the patient has anxiety? And that makes their pain worse, doesn't it? So maybe they need something for anxiety to make the pain medicine work. These are things we have to keep our doctors apprised of, and things we need to be aware of, how to take care of our patients. So let's go back to that table 8.8, problem solving. So check the analgesic order. Be sure it's the right dose, the right patient, the right time, and what's the onset, peak, and duration of the analgesic. So are the times right? So knowing when the peak is, what's the peak time that this medication is in the patient's blood system and they're feeling that pain and that relief? And then how long does it last? Also consider an alternative prescription if you need to. And then the right patient, right route, right analgesic, right dose, right time. And be sure that you collaborate with the patient and other nurses, pharmacists, and family. You know, I had a friend who was working, and the nurses had different attitudes about pain management of this one particular patient. One nurse wanted just, you know, they were all PRNs, but she said, okay, just give them all to the patient. But the patient didn't need them all. So don't just always go by what other nurses say. It's good to collaborate with another nurse, but don't just give drugs to give drugs. Be sure that there's a purpose. Please don't be one of those nurses that just sedate your patients. Okay, I think that was an interesting lecture about pain management, very important. So thank you for listening.